So our third speaker of the day is Nicole Townsend and colleagues, both being from the University of Colorado and Ohio State. It's unintended stray energy from the monopolar instrument. Beware of dispersive electrode cord.
Thank you. And what's this? Yes, okay, great. Thank you. My name is Nicole Townsend. Thank you to the SAGES Committee for allowing me to present this research. I have no conflicts of interest to disclose. Stray energy transfer is a mechanism of patient injury, and antenna coupling is a primary factor. As energy travels from generator to the active electrode, or the Bovie or L hook, stray energy is emitted from the cord. As this stray energy is transferred, or as this stray energy is emitted, it is transferred or captured by adjacent instruments, and this energy is then released as heat in the non-active electrode instrument. The intensity of stray energy transfer is directly related to the intensity of the heat in the non-active electrode instrument. So electricity travels in a circuit from the generator to the active electrode, or the Bovie, and then the dispersive electrode, or the grounding pad. And nobody has identified the nature of stray energy transfer in the dispersive electrode and its role in thermal injury. So our hypothesis is that there is equivalent antenna coupling or stray energy transfer from the dispersive electrode as the active electrode. And our specific aims were to, one, identify that antenna coupling occurs, as well as surgeon modifiable factors to reduce stray energy transfer. So we placed bovine tissue in a laparoscopic trainer using our previously developed antenna coupling model. We then modified the orientation of the dispersive electrode cord to determine the extent of stray energy transfer in various conditions. Our first observation was that there is equivalent energy transfer between the active and dispersive electrode. So as energy is traveling throughout the circuit, it is at equal risk in any part of the circuit of emitting that stray energy and that energy being captured and translated into thermal heat. So when the dispersive electrode cord is isolated from the circuit and the active electrode cord participates in stray energy transfer, there's an equivalent amount of that capture when you isolate the active electrode cord and incorporate the dispersive electrode cord. So then we began to look at how to reduce the amount of stray energy transfer and reduce that risk of thermal injury. Our first was to just simple separation of the cords. So if you keep the cords far away from each other, so not in proximity, it decreases that amount of stray energy transfer and therefore decreases the amount of thermal energy, and we were able to significantly reduce the amount of heat in the non-active electrode instrument. The second thing that we did was to add a second dispersive electrode cord or dispersive electrode or grounding pad. So the simple addition of a second grounding pad dramatically decreases the amount of energy transfer and therefore the amount of heat. We further looked at various uses of power and the power in the generator, and if you use cut mode instead of coagulation mode, as well as looking at activation time, using 5 seconds of activation time versus 15 seconds of activation time, we saw similar decreases of decreased energy transfer and therefore decreased heat in the tissue. So to what we draw from these conclusions in a clinically relevant way is that the cords in the system need to actually be separated from one another. Otherwise, the stray energy gets captured in the system and you're at increased risk of thermal injury. You can also add a second dispersive electrode into that system, and that will dramatically decrease the amount of stray energy transfer from the dispersive cord part of the circuit. So as surgeons, what we can do to decrease the risk of stray energy transfer and thermal injury is to keep the camera cord separate from the monopolar circuit, both active and dispersive electrode, add a second dispersive electrode using cut mode, and preferentially over coagulation mode, as well as short activation time of activation of our Bovie or monopolar instruments. Thank you very much.
Nice presentation. We'll open up to the audience for questions.
So Nicole, that was an excellent presentation. Can you put this in a clinically relevant context for us? You know, at the Fuse group yesterday, we were talking about how the cord, if you draped an active electrode cord across a cardiac rhythm device, you know, implantable cardiac device, it would disrupt the function of a cardiac device. So where can you think that I, as the general surgeon, could take this information and change my practice in the operating room?
Thank you for the question. So that's a great question, and there are some actually very simple maneuvers that you can do in the operating room to change your practice. At least in our operating rooms, all of the instruments and all of the power generators are frequently in one tower. And so what you can do is actually remove the power generator from that tower, place it on the other side of the patient, and that completely removes the monopolar generator from all of the other instruments. And so that actually is a very simple maneuver to kind of isolate that power generator and decrease the risk of stray energy transfer in your operating room. Also, addition of a second dispersive electrode is, again, a very simple maneuver where you don't have to really change a lot of your practice other than the location or addition of simple tools.
Edward Aliang, University of New Mexico. That's a very interesting study, and again, like the other speaker mentioned, very applicable with fuse and everything. Since the distance is not directly proportional typically to the transfer, did you look at what sort of minimum distance you would achieve the same sort of effect? And did you also look at any sort of insulation sort of materials also to actually help deflect that sort of energy transfer? Thank you.
Thank you for the question. So in this particular study, we didn't look at specifically a minimum amount of distance. In our previous studies looking at antenna coupling with the active electrode, about 15 centimeters of separation is usually sufficient to overcome a lot of the stray energy transfer. So, you know, we're all very much in the routine of bundling all of our cords as they come off of the operating room table, and so kind of, again, draping the active electrode cord on one side of the patient and everything else on the other side of the patient is sufficient to mitigate that effect. And we have not specifically looked at an addition of an insulation, I think, but I think that's a great idea and something that we could explore. Absolutely. Thank you.
My name is Dwight Yen. I do reviews of these devices for the Food and Drug Administration. Thank you for sharing your investigation. We're seeing a lot of single site type of instrument and being developed. How would you advise people that are using that kind of configuration to minimize what you've just presented?
Thank you. That's an excellent question. We actually have also looked at single incision laparoscopic setups, and honestly, because all of the instruments are forced to go through a single port, it's actually very difficult to mitigate the effect of stray energy transfer. And in our data, we were able to demonstrate, even with all of the maneuvers we've been able to identify to reduce the amount of stray energy transfer in a laparoscopic system, the SILS orientation kind of forces the system to overcome all of those things. So even if you try to separate all the cords, when they come all back in that single port, it's very difficult to reduce the amount of stray energy transfer. Thank you.
I had one question. I assume that the insulation was intact in these cords, because one of the problems we've certainly seen with the instruments themselves is that there can be a nick in the insulation, and you can really get some capacitance coupling that way, and that can be a problem. So my question is, assuming that they're intact, and I'm sure you check that, since especially these things are right out of the box, so they ought to be intact. But would it improve to them to increase the size of the insulation? Because, you know, with all these cords going all over the place, it's a very cluttered environment. So how would you address that?
That's a great question, and honestly, we've not explored increasing the amount of insulation on the cord. So all of the cord insulation is intact. But what we've recommended is very much that even the simplicity of just isolating the generator on the other side of the patient is a way to kind of reduce that clutter of all the cords going everywhere, and just keeping like the two pathways of cords, the generator on one side and the cords on the other. But we've not explored kind of increased insulation on the cords themselves to see if it will reduce stray energy transfer.
Good. Yes.
One more follow-up question. Did you look at any non-monopolar devices, like, for example, bipolar or ultrasonic or anything, to see what that was like?
Absolutely, and because the bipolar device actually in the electrical circuit is kind of within the device itself, it doesn't participate in antenna coupling anywhere near the amount of as the monopolar instrument. And so while we've looked at those devices in a lot of our antenna coupling studies, we didn't look at that as intentionally in this because we know that ultrasonic devices, bipolar devices, don't contribute to stray energy transfer anywhere near the amount that the monopolar instrument does. But we have confirmed that that use the monopolar instrument in laparoscopic settings, open settings, any monopolar instrument use is able to participate to this extent in stray energy transfer. Thank you so much.
Okay, thank you.